Okay, good evening, everyone. Welcome to tonight's Knowledge in Motion lecture. We really appreciate you joining us. I know that I'm a little bit short and a little tough to see some of the folks in the middle, but I need to stay here for the webcast because we have a lot of folks online tuning in from various parts of the world. So thank you very much for joining us. Before we begin tonight's program, just a few housekeeping items as always. Please remember to turn off your cell phones so that everyone in the room can enjoy the lecture and also the people on the webcast. For anyone who needs it, the restrooms are down the hallway where you entered, just to the right. Food, of course, is over here by Miguel. Please feel free to either get some dinner or raise your hand, and one of our volunteers would be happy to help you with that. Please recall that after the lecture, during the question and answer period, please raise your hand and one of us will bring you the microphone because we do have people online and they won't be able to hear your question unless you speak through the microphone. So when we get to that part, we'll remind you about that. And if there's anything that you need during the lecture, water, napkins, what have you, please, again, just raise your hand to flag and one of our volunteers will be there to provide assistance. At the end of the lecture, please remember to fill out our survey that you received at check-in, and volunteers will also be available if you need any assistance with that. We really rely on your feedback when we think about next topics to tackle with the Knowledge in Motion lecture series, and really appreciate you taking the time to fill that out. So thank you again for joining us for the Spaulding New England Regional SCI Center Knowledge in Motion lecture series. And thanks to all in the room, and we're also very happy to have a very robust group on the webcast this evening. So thank you to all who are joining us from around the world. We have attendees from 30 states across the US and 4 countries, including Mexico, Bolivia, Canada, and India. So thank you to all for joining us from all around the world. I am Dr. Sherry Blauet. I am the Director of Dissemination and Knowledge Translation for the Spinal Cord Injury Model Systems. And this evening, we also have the pleasure of, actually, I think he just stepped out, but our Chair of the Department of Physical Medicine and Rehab, Dr. Ross Lafont, is also here with us this evening, so we thank him for joining. So our topic this evening, I think, is one that is extremely interesting and also something that impacts a large proportion of individuals with spinal cord injuries, and that is understanding the spectrum of autonomic dysreflexia. And for this, we're very appreciative to have Dr. Ryan Solinsky, who's both a friend and colleague here in the Department of PM&R at Spaulding and on faculty at Harvard Medical School. Dr. Solinsky is a spinal cord injury medicine physician scientist who sees outpatients with spinal cord injury in Spaulding, Charlestown, and also is involved in clinical research based at Spaulding, Cambridge. He spent some time at Case Western Reserve University, as well as the University of Washington, and then Kessler Institute for Rehabilitation, where he did a spinal cord injury fellowship prior to coming on faculty here at Spaulding. Some of his work has been focused on really thinking about the gap between bench science and how to translate that to spinal cord injury, the spinal cord injury population and consumers, particularly focusing on device development to improve neurogenic bladder function and also protocols to really manage autonomic dysreflexia. So he's truly an expert in this area, and we're really pleased and honored to have him with us here this evening. So without further ado, we'll welcome Dr. Solinsky.
All right. Excellent. Thank you for having me. I'm very excited tonight to talk about our work understanding the spectrum of autonomic dysreflexia. This is a topic that I've been passionate about for quite a while. When I first started talking to patients with spinal cord injuries, when I was a first-year medical student now over 10 years ago, I remember one of the things that they really stressed to me, one of the things that they wished physicians knew about was autonomic dysreflexia. And those early conversations really lit the fire for me to understand this condition a little bit better and actually started a lot of the research that we're still doing today. I do think it's critically important to connect with patients like yourselves and clinicians like yourselves, really sharing what we've learned to date, bringing you up to speed on some of the research and letting you know that as a community, as a scientific community and a clinical community, we're pushing forward. So sincerely, thank you for having me. I have no financial disclosures relevant to any of this presentation. As I mentioned, the research that I do is primarily focused on understanding the autonomic nervous system after spinal cord injury, specifically as it relates to autonomic dysreflexia. As such, we are going to talk about several medications that can be used for autonomic dysreflexia, or AD as I'll interchangeably refer to it. All of the medications are generics. I won't use any brand names or anything like that. Definitely will. Thank you. Okay, so autonomic dysreflexia. So autonomic dysreflexia is a condition that can happen after spinal cord injury. It's characterized by an increase in blood pressure, and that blood pressure increase happens in response to pain. The way I like to think about it is before a spinal cord injury, you have an intact neuroaxis. So your brain connects to your spinal cord, connects to your peripheral nerves. When you have some sort of painful signal, let's say that your bladder is too full, that signal goes from your bladder back to your spinal cord. And when it gets to your spinal cord, it sends a message to the blood vessels in that area. Basically, the spinal cord says, hey, there's something painful happening. Maybe we're bleeding to death. And so it tells the blood vessels in that area, we might be bleeding to death. Let's squeeze all those blood vessels really tight. That signal then ascends up the spinal cord to the brain. And the brain says, nope, you're not bleeding to death. You just have a full bladder. I told you you shouldn't have had 3 Cokes. Even though they're the tiny cans, they still count. That signal then goes back down your spinal cord to the nerves, where it tells those blood vessels in that area that it's okay to relax. No blood pressure change exists to any great degree because you have that intact neuroaxis. However, after a spinal cord injury, the equation is a little bit different. So while you still have the first part of that reflex intact, saying, hey, the bladder's a little bit too full, let's squeeze down all the blood vessels so we don't bleed to death, that signal can't make it up to the brain. That means that more and more of those nerves in your spinal cord get engaged and tell those blood vessels to squeeze tight, bringing the blood pressure higher and higher and higher until it can get to dangerously high levels. In some folks, this blood pressure, the systolic blood pressure, that's the top number. If you're thinking of 120/80, the top number is the systolic. That's gotten as high as 325 millimeters of mercury, which is an astronomically high number. It can lead to things like stroke, retinal hemorrhage, death, all bad things that we want to avoid. In terms of presentation for autonomic dysreflexia, there's quite a bit of variability. I mentioned the classic symptoms of having blood pressure be increased, and that's actually the definition of autonomic dysreflexia, is that your systolic blood pressure, that top number, has to go up by at least 20 millimeters mercury, so 20-point increase in your systolic blood pressure. Keep in mind that after a spinal cord injury, lots of folks have systolic blood pressures that are closer to 90 or 95 or 100. So if your blood pressure is 120 and you usually live at 95, that's technically dysreflexia. The other classic symptom that comes with dysreflexia is a slowed heart rate. To understand this, I think we need to take a step back and understand that during dysreflexia, you're really having a war inside your body. So you're having a war in your autonomic nervous system between the sympathetic nervous system and the parasympathetic nervous system. So remember that the sympathetic nervous system is that fight or flight response. It is getting you geared up, your muscles are ready to run away from a tiger or pick up a spear and try to stab it. You're not trying to go to the bathroom or digest food or do anything else. You're there to fight or run away. The parasympathetic system is the opposite of that. So that is the rest and digest aspect of the autonomic nervous system. So that is the relax, we need to process the food, turn it into fuel so that we can run away from the tiger in the future. During autonomic dysreflexia, usually those two systems are fairly in balance, sympathetic and parasympathetic. But during autonomic dysreflexia, below the level of injury, you get all of these sympathetic manifestations. Okay? So having those blood vessels squeeze down, protect yourself from bleeding to death, that's a sympathetic response. Above the level of lesion, your brain senses that, hey, there's this increase in pressure, we need to bring it down, and it does that by engaging the parasympathetic nervous system. And they kind of fight sympathetic, parasympathetic. The way it tries to bring the blood pressure down is by engaging the parasympathetic nervous system to slow down the heart, doing anything it can to pump less blood. So classically, increased blood pressure and slowed heart rate. Other symptoms that can happen with dysreflexia can again be broken down parasympathetic above, sympathetic below. So parasympathetic manifestations can be things like headache, flushing, increased secretions. So the headache is because the vasculature in your head dilates, and it's pain-sensitive vasculature, so you can get a headache. You can get flushing, where everything above your level of lesion can be flushed and more red. In some folks, you actually see a clear delineated line where everything above is red, everything below is pale. And you get increased secretions, either runny nose or bronchial secretions. On the sympathetic side of things, we can get things like blurred vision, we can get sweating, we can get goosebumps. Those are all sympathetic manifestations of dysreflexia. Or the most common manifestation of autonomic dysreflexia, and probably the scariest one, is no symptoms at all. And this makes autonomic dysreflexia really, really hard. Because in some cases, it can be severe, and in other cases, it seems to just pass. And everyone is different. So when I give this presentation to scientists, we break this slide down into several different slides, and we talk a bunch about the immunohistochemistry and things like that. I want to hit the high points here because I think it's important to think about the pathophysiology of what's causing dysreflexia, because it determines why everyone is a little bit different. So here's a couple of lessons that we can learn from all of those animal studies that have been done in the past. Autonomic dysreflexia can change depending on the source of pain. So that is not only within individual, but it can be between individuals. So there's good evidence in animal models that if you have one type of nerve fiber, A delta fibers, you can get increases in heart rate when you have dysreflexia. If you have a different type of nerve fiber, C fibers, you get increases in blood pressure. Now, everyone has some mix of A delta and C fibers in their nerves, and everyone's probably a little different. So one person might have 80% C fibers in their bladder, and so when they get bladder pain, they get an increase in blood pressure. That same person might have a higher proportion of A delta fibers in their leg, in the skin. So when they sit on a pen cap and they get dysreflexia, their blood pressure doesn't go up as high. Instead, they get heart rate changes. So that's some idea of what's explains some of this variability in dysreflexia. Additionally, autonomic dysreflexia can be different in incomplete injuries. And this isn't thinking about injuries in terms of motor incomplete or sensory incomplete like we do when we test muscle strength and we do the light touch and the pinprick and all that. This is autonomically incomplete. This is something that's just starting to be realized, is that while we do have motor scores and sensory scores and some ways to quantify that, we're not too good at quantifying how much autonomic function people have left. And if you're someone that has some intact autonomic function going through your spinal cord, even if you're unable to move and unable to feel things, you're able to regulate signals inside the cord. So your presentation could be different from someone that might be able to move and feel, but has no autonomic regulation. Additionally, autonomic dysreflexia can change depending on the rewiring of your spinal cord. So we know that the spinal cord isn't just a static cable. After an injury, the spinal cord below The injury isn't just waiting for one connection, something to bridge the gap and then reconnect everything. That spinal cord below the level of injury is actively rewiring itself. Sometimes it's boosting signals, sometimes it's decreasing them. Sometimes those boosted signals mean that you might get a new movement, or you might get some sensation in an area that otherwise didn't have any. It can also mean that the autonomic nervous system gets engaged. So the sympathetic signals from a bladder being too full or your bowel being backed up can get magnified inside the spinal cord, and you leads to greater manifestations. And finally, autonomic dysreflexia can change depending on the reactivity of the vessels. So we talked about how parasympathetic manifestations happen above the level of injury during AD. Below the level of injury, you're basically getting sympathetic engagement. However, when people aren't having dysreflexia, there's very little sympathetic activity that happens in the body. This means that those blood vessels really get starved for that signal. They start perking their ears up and saying, if there's any sort of sympathetic signal, we're going to react. That, of course, happens to a varying degree. What it means is before your injury, if 5% sympathetic signal meant 5% constriction of your vessels, after an injury, 5% sympathetic signal could mean 20% constriction of your vessels, or 60%, or 70%. Your body could get so excited that there's some sympathetic activity that it squeezes all the blood vessels and your blood pressure shoots up really high. That, again, happens to varying degrees and probably starts to explain why people present differently with autonomic dysreflexia. Okay, so that was a lot of slides and animal talk. Let's bring it back. I think a good way to illustrate this is with a case. So this might potentially be one that resonates with some of you. Imagine that you go to bed and you're feeling a little bit tired and just off from the day. You get woken up at 3 a.m. with some spasms in your legs. They seem like they're getting worse. You end up not sleeping very well. You start to get a little bit of a fever and then chills and then feel this bone-chilling cold that comes over you. You get a headache that comes on and builds and builds and builds until it's hard to take. You decide that something is clearly wrong. You're starting to get anxious. You check your blood pressure, and it's 185/95. So this is clearly outside of what most people's blood pressure is after a spinal cord injury. You call an ambulance. They transport you to the emergency department, where you are greeted by that lovely scene. In the emergency department, your blood pressure has now come down. It's 160/95, which everyone there tells you is almost normal. But you stress them that this is far outside my baseline. Somehow between the crowded setting and the excruciating headache that you have, it's hard to convey to them the pathophysiology of CGRP fibers rewiring at A delta. Somehow that misses your mind. You give a urine sample. The initial analysis looks like it's positive for a UTI. They tell you that you're going to be admitted. You're started on IV antibiotics, and your blood pressure spikes as high as 200/120. But over the next day, you start to feel a little bit better. Your blood pressure comes down to around where it normally is at. You stay on IV antibiotics for 5 days before the cultures come back. It turns out that the bacteria that's in your bladder is resistant to an oral agent. You're given pills and discharged home. So that's autonomic dysreflexia from a urinary tract infection. You don't need to raise your hands, but that is an extraordinarily common presentation of dysreflexia. It happens all the time. And those times when your blood pressure gets really high, over 150, over 180, over 120, those are the times when we start to worry about those complications of stroke, retinal hemorrhage, death, those really bad things. So that case is clearly dysreflexia. I think most people would agree with that. How about this case, though? Imagine that you are at home, you're watching Netflix, and you are distracted with your phone. I'm sure no one can relate to this. You look up and you see this. And you know that you could find the remote. It's probably going to take more than 8 seconds. You really want to keep watching because you want to see Ross have his first baby. I think this is an old episode of Friends. Even though you know that you're supposed to make dinner and do one other thing. 15 minutes goes in, Ross has the baby, it's wonderful, and you get this sensation. You get this warm feeling that kind of rises up, and you get just a little bit of a twinge in the side of your head. And with that, you remember that thing that you were supposed to do. You're supposed to cath. 15 minutes passed, you go, you cath, there's 550 cc's, that warm feeling goes away, definitely don't have a headache now, you're fine. How about that? Is that dysreflexia? The answer is probably yes. It's not the type of dysreflexia that is going to lead to a stroke or bleeding in your eyes, but it's still probably dysreflexia. That begs the question of how common does AD actually occur? When I talk to clinicians about this, I always pose it as an audience question, and they routinely underestimate it, and they say that it happens 3 to 4 times a month. The answer is that it happens very commonly. Using things like ambulatory blood pressure monitoring, where you check blood pressure every 10 to 15 minutes, it's shown that people that are at risk for AD probably have between 10 and 15 episodes of AD every day. We either just happen to catch it or it resolves on its own. That then leads to the next question. This is the scientific gears that just go and go. If it's not head pounding, 10 hours in the emergency department, having to be on IV antibiotics, AD, is it that bad? The answer is we don't know. We don't know. In fact, it's one of the things that we are looking at in some of the studies that we're doing at Cambridge, trying to see if all of these increases in blood pressure have negative side effects. What we do know is that cardiovascular disease is now the #1 source of mortality for individuals with chronic spinal cord injury. So it's at 40%. It's higher than problems with the kidneys, it's higher than problems with the bladder, it's higher than pneumonia, all things that in the past were the leading causes of death. Now it's cardiovascular disease. We know that people that have tetraplegia have about 20% higher risk of cardiovascular disease than if you have paraplegia. We know if you have a complete spinal cord injury, that's motor and sensory complete, you've got about a 40% higher chance of cardiovascular disease than if you had an incomplete injury. We think that one of the reasons why, or how autonomic dysreflexia ties into this, is that all of those increases in blood pressure lead to increased shear stress inside the vessels. When I first heard this, it took a while for it to sink in. I'm not at heart a scientific person, so I had to create analogies to make things make sense. And the analogy that I always like for blood vessels is rain gutters. I understand rain gutters. So to me, essential hypertension, when blood pressure is over 140 or 130 with the new guidelines, that's like if your downspout on your gutters is plugged up with leaves. You have increased pressure that's always going to be there. It's not good for your gutters. It's not good for the downspout. Things can break and bad things can happen. But other things that could damage your gutters would be if you had a giant rainstorm and all of the water flooded the gutters and was spraying out the bottom, and that happened 10 to 15 times a day. That probably also is not very good for your gutters. Similarly, probably not great for the vessels. Other implications, and I think this one's particularly interesting, are or relate to the immune system. So there's been good data that autonomic dysreflexia can lead to what's called immune paralysis, kind of a kitschy name. They've shown in animal models that repeated episodes of autonomic dysreflexia lead to all of these rushes of stress hormones, and those stress hormones can lead to a transient, short-lived period of immunosuppression that happens after an AD episode. In animals, they go in, they look at the spleen, and they can find changes in spleens of animals that have had many episodes of dysreflexia. Again, thinking about the immune system. To me, this starts to make sense, because the story that I hear not uncommonly is that someone is out for a fun day outing, they're a little bit behind on their calf, they get that warm feeling or whatever your manifestation of AD is, they calf and their volume is 700. The next day, they feel like they have a little bit of a urinary tract infection, or they're just feeling kind of down and out about it. Maybe it goes into a full UTI, maybe their body kind of fights it. Connecting the dots here, when the bladder is full, it's squeezing and there's increased pressure inside of it. Usually it's squeezing against a closed outlet valve, that detrusor sphincter dyssynergia, where they're not working in coordination. That increased pressure then causes ischemia, where there's decreased blood flow to the walls of the bladder. The walls of the bladder are covered in what's called urothelium, the cell type, and that's very susceptible to decreases in blood flow. So now you have a high pressure bladder full of various bacteria, weakened defenses with your urothelial lining, pressure driving in, and because there's AD, some transient immunosuppression, so your whole body defenses are down. Next day, not feeling great. I think that's an interesting implication to think about, not one that's commonly thought about. And the third implication that I want to stress, especially to the clinicians, is the psychologic implication of being at risk for AD. Even if you're not having AD, my friends that I have that have spinal cord injuries tell me about the fear of just being out there and knowing at any point I could have a dysreflexic event. It's kind of like having an aneurysm that's in your head and thinking there could be some serious consequences that right in the middle of me doing something fun could wipe out the next day or the week or the month after that. So that's not to be minimized. The other very unfortunate psychologic implication that can come from AD is having to explain that diagnosis. So these same friends will tell me about a calculus that they go through. They say, I know I'm having AD. I tried to figure out the cause of it. Is this the type of AD that I'm willing to spend the next 4 hours or 6 hours or 8 hours in an emergency room explaining to people what AD is? I would argue that is not a good situation to be in, and we as clinicians need to do a better job at educating. We'll also go through a few tips for everyone today that will hopefully make these interactions when you do need to go to the hospital a little bit easier. Before we get there, though, I want to touch on a few other symptoms that can happen with dysreflexia. So we talked about those classic symptoms of increased blood pressure. That's part of the definition, has to be there, but also slowed heart rate. These are kind of held as dogma with people who know about dysreflexia that say, oh, your blood pressure's up, that means your heart rate has to come down. What it turns out is that there are significant shades of gray here, just as with everything. So commonly, you can either have an increase in your heart rate or no significant changes at all. We did a study in 2016 where we identified 450 episodes of AD, and about 70% of them had tachycardia, heart rates that went up as opposed to ones that went down. Again, depending on all those variable factors. The important take home is that if you're in the emergency room with a pounding headache trying to explain pathophysiology of autonomic dysreflexia and someone tells you it can't be AD because your heart rate is 90 right now, you can say, please refer to a retrospective review of safety, and then you can read the reference to that. The other misconception that sometimes people have about dysreflexia is related to the neurologic level of injury. So we touched on this a little bit, how the neurologic level of injury at or above T6 is is typically thought of as that's the risk factor for if you're going to have dysreflexia. Again, that is neurological level of injury as determined by motor and sensory testing, so not necessarily capturing all the autonomic changes that can happen. In fact, there's been cases of autonomic dysreflexia reported as low as T12. So people with lower level spinal cord injuries can still have manifestations of AD. And that actually gets to some of the research that we've been doing over in Cambridge. I want to present these two slides because I think that they're really interesting and I like geeking out about science things. We'll go back to the other stuff. So we're looking at trying to determine how much spared autonomic function people have. Motor and sensory are good for guessing, but they don't always capture the whole picture. One way we do that is by recording a bunch of different autonomic markers and perturbing the system, causing the autonomic nervous system to be engaged. In this example, we're engaging the autonomic nervous system by having someone's hand and dunking it in a bucket of ice. Okay, that is a controlled, mildly painful signal. What you're going to see on the bottom is that systolic blood pressure, that top number. And on the top, you're going to see a nerve tracing. So this is a sympathetic nerve tracing. You're watching each one of the bursts that are happening. So this is an individual without a spinal cord injury. We take their hand, we dunk it in the bucket of ice. Their blood pressure goes from 140 or so at baseline up to 160 over the course of 3 minutes. Down on their right leg where we're recording their nerve activity, you see all of these bursts of activity. That's individual firing of the nerve. After 3 minutes, their hand is taken out of the ice water. Their blood pressure comes back down. You can see on the bottom tracing. And in general, you see less spiking behavior. So that is less engagement of their sympathetic nervous system. Compare this, if you will, to an individual with a T3 complete spinal cord injury. So clinically complete, so motor, sensory are not present. However, because it's a T3 injury, right here, their arm has no deficits. Motor, sensory, everything is intact in their arm. And we're taking that hand and dunking it into ice. So you see that this individual starts with their blood pressure around 150. Over the course of 3 minutes, it goes to about 160 and then drops towards the end. Interestingly, because of the spinal cord injury, we see almost no spiking activity. So no sympathetic engagement below their level of injury. That's when the interesting thing happens. This person takes their hand out of the ice water. Their blood pressure fluctuates wildly, at one point going from 135 to 190. So there's a dysreflexic episode right there with their hand coming out of the ice water. And you see all of this spiking activity on the top, all of these bursts of sympathetic. So this is someone that has an autonomically incomplete injury. They're able to recruit sympathetic fibers below their level of injury, despite having a clinically motor and sensory complete injury. When we take the test one step further and take that person's left foot and put it into ice, we see something else that's interesting. So again, left foot is going into a bucket of ice. Right side is having the sympathetic nerve recording. So the left foot goes into the ice. Their blood pressure goes up to about 180. At that point, it's dysreflexia. We take the foot out of the ice. We don't want to be causing that. Blood pressure increases a little bit more and then comes back down. But there's almost no engagement of sympathetic nervous system on the right side. So pain on the left side is not leading to activity on the right. There's no spreading from one side to the other. This starts to get at that rewiring that we were talking about, trying to get insights into a person's pathophysiology inside their spinal cord about what the wiring is doing. Is it in parallel? Is it in circuit? Is it doing other things? This also really stresses in my mind that, as we mentioned, neurologic level of injury is not the whole story. We need to be considering more. Okay. So you have an episode of autonomic dysreflexia. What are we going to do about it? Luckily, There's good guidelines on how to manage dysreflexia. The first and probably most important step is conservative management. That we'll go through in a little more detail. The next step is trying to identify what the source of the dysreflexia is, trying to find what pain is kicking all of it off. And if that doesn't work, going on to medications. There are consortium guidelines that are put out by the Consortium for Spinal Cord Injury Medicine that discuss using medications if blood pressure gets to be over 150. So that systolic blood pressure, that top number is over 150, think about using medications. These guidelines are from 2001. They're actually working on new guidelines right now that should be out in 2019. They're a good place to point providers. If you're working with a primary care doctor and they're not sure how to manage this, say, here's this wonderful booklet, or here's a reference to it. It will walk you through high points on how to manage dysreflexia. For conservative management, I mentioned this was the most pertinent step. The first thing that you want to do is sit up or have someone help you sit up. You might remember from inpatient that first time after being in bed for 5 or 10 days, you sat up and the lights felt like they were the shades were coming down, the lights were going out, you felt like you were going to pass out. So that is your blood pressure falling, and that's exactly what we want to have happen if your blood pressure is too high. So sitting up is an easy, non-medication option to bring your blood pressure down. If you start to feel like you're going to pass out, have someone help you lie back down. The next step is to remove any constrictive clothing. So if you wear TED stockings or an abdominal binder, those are all meant to increase your blood pressure. Take those off, your blood pressure will be able to come down. Once you do those two things, you bought yourself a little bit of time. The next big step is to look to identify that source, trying to find where that pain is coming from. The most common source of dysreflexia is bladder. I had a mentor in med school who used to say the top 10 causes of autonomic dysreflexia are bladder, 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 bowel, bladder, skin, bladder. So always look at the bladder first. If you do intermittent catheterization, make sure that you catheterize your bladder, ideally with lidocaine beforehand if you have that available. If you have a suprapubic or a Foley catheter, some sort of indwelling, making sure that it's flushed, that it's not clogged, that it's not kinked, that there's not something that's preventing it from draining. If that doesn't seem to be bringing down your pressure, the next step is to look at the bowels. So if you haven't had a good bowel movement with your program for the last few days, that could be what's causing the dysreflexia. You want to try to search and see if there's any stool impacted that you can get your hand on to get out. Again, using lidocaine if that's something that's available. The third step is to assess your skin. So seeing if there's some pressure injury or deep tissue injury that's just kind of lurking, or there's been cases where people's shoes have been too tight, or as I mentioned, sitting on a pen cap. Those are all things that you want to look out for because that's easy to remove in the latter two cases, not pressure injury, obviously not easy to remove. If those don't work, then you need to go to medications. Until a few years ago, there was really limited evidence in terms of which medications worked. When I was out at the University of Washington, we did a study looking at a protocol of conservative management and medications. And this is shown to be relatively effective. So conservative management, as I discussed, is that important first step. After that, we do nitroglycerin paste. That's what we do here as well, followed by hydralazine, which is a pill. In the first step of those 410 episodes of AD, conservative management resolved 10.6%. That's likely a gross underestimate. I would guess they're closer to 90 to 95. People just weren't recording when you sit someone up and their blood pressure comes back down. Next, we apply 1 inch of nitroglycerin paste. At University of Washington, we put it on the upper chest. When I was in New Jersey, they put it on the head. Somewhere that you know that there's nitro paste on you. When you're doing that, you want to make sure that you have a glove on or that your provider has a glove on, because if they put 1 inch of nitro paste on their finger and then try to wipe it on, both of you will have your pressure dropped and one of you will be on the floor and the other person will be in a chair. That resolved almost 50% of dysreflexia with that first inch of nitro paste. If that pressure didn't come down within 10 minutes, wasn't below that 150 millimeters of mercury, that's that threshold, we did another inch of nitro paste. That increased the efficacy, the resolution, to over 80%. So we didn't even need to go to the other medications. If it still hadn't come down, we gave 10 milligrams of oral hydralazine. And if 10 minutes after that still hadn't come down, we gave 10 milligrams more. Together, those 5 steps resolved 97.6% of dysreflexia. So this is a protocol which I continue to stress has good efficacy and really should be the gold standard for comparing other newer treatments of how you might manage dysreflexia. I want to return to nitroglycerin paste or topical nitro ointment or whatever you want to refer to it as. This is the agent that I send home with patients, and I think it's a great medication. When you're using this medication, I mentioned having to wear a glove, but there's other things that clinically we can give to you. One important thing would be knowing how long after I put it on should I start to see some effect. So we've done a study looking at the onset of action of nitro paste, looking at those patients out of University of Washington who had really rip-roaring AD that had been going on for a while. The nitro paste worked between 9 and 11 minutes in. So that's working, being classified as the blood pressure stops going up and drops by 10 points. Okay. In a prospective study that we're currently doing, where patients are having cystoscopy, so they're having a urologic procedure, which commonly causes dysreflexia. We apply nitro paste in those individuals, and the time to onset happens closer to 90 seconds. So depending on how entrenched the autonomic dysreflexia is, look for somewhere between 2 and 10 minutes before you're starting to see an effect. The nice thing about nitro paste and why I like it better than some of the other medications is that when you see the blood pressure starting to come down, you can wipe it off. That's a very important thing. That's not going to sit around in your system like if you had to take a pill that was going to last 2 hours and you have to watch out for. The other thing I really like about nitro paste is that there's evidence that it has dual action. So there is a beautiful Italian study that was done about 15 years ago now, which showed after spinal cord injury, if you gave someone nitric oxide, so the same active ingredient that's in nitro paste, it actually caused external urethral sphincter relaxation. So bladder neck relaxation from nitro paste, or nitro spray in that case. This is great.
So that's contraindicated to take a pan or some kind of medication?
It is not. It is not. The really nice thing about this is that we mentioned 7, 8 of the main sources of autonomic dysreflexia were bladder. So if we can cause the vessels to dilate throughout the body and attack it at its source of relaxing the bladder a little bit, it's 2 birds with 1 stone, dual action. When we've studied this a little bit deeper, we've shown that nitro paste and that big data set had faster time onset of action and a larger drop in the systolic blood pressure if it was bladder-related dysreflexia versus if it was from some other source. So a great first-line medication to be aware of. The other important thing to consider with nitro paste is when you wipe it off, how long does it take before it loses its activity? So this is important because if you have to wipe off the nitro paste and you didn't address whatever was causing the dysreflexia, you might have another spike in blood pressure, and you need to be watching out for that. We have a small study that's ongoing looking at that, which shows that it stops working in less than 2 minutes with a pretty wide standard deviation. So a safe estimate is 5 minutes after you wipe the nitro paste off, you should expect that the blood pressure might come up. If it hasn't come up 5 minutes after, you're probably pretty safe. You might want to check it one more time, but you're probably in the clear here. You've addressed whatever the source is of the dysreflexia. The last medication insight that I wanted to talk about was lidocaine. So I talked about this briefly with if you're having dysreflexia, using lidocaine to pass a catheter or clean out your bowel, those are all things that are in the consortium guidelines. We did a study that was just, I guess it was published online this year. It'll come out in print next year, probably. Looking at pre-treatment with lidocaine before catheter change. So this is individuals who are at risk for dysreflexia, who are having routine cath changes. If you have a suprapubic, that means putting lidocaine in through the suprapubic, flushing it with air, and then changing it. Same thing with a Foley catheter. We showed that doing this, giving 10 milliliters of lidocaine, decreased AD incidence from 50% to just about 15%. So a significant drop there. Additionally, when you change the catheter, the blood pressure after you gave lidocaine only increased by about 10 to 15 millimeters mercury. If you didn't give lidocaine, it went up by about 25. So you're tamping down the sympathetic nervous system. That logically makes sense because lidocaine blocks C fibers, which you are all now experts in what C fibers do. They change blood pressure. So by putting lidocaine in the bladder, you're blocking C fibers, stopping blood pressure increase. The cogs connect. The other interesting insight into lidocaine is that the time to onset of action is about 90 seconds. So it isn't something that's going to take you a bunch of extra time. Using a little bit of lidocaine can decrease the dysreflexia. Okay. So what if you're not someone that is whisked off to the emergency room all the time, but you just are that person that has that warm rush every once in a while? What can you do to try to decrease autonomic dysreflexia? The answer is actually pretty reassuring. Just staying on top of the potential causes is beneficial. Those potential causes are all the things that you learned in inpatient rehab and that you know deep inside you now. So staying on a schedule for managing your bladder, staying on a schedule for your bowel, making sure that you're having a good bowel movement with every program, making sure you're doing skin checks, eliminating all of those causes, 10 of those causes, that could be leading to dysreflexia. Other things that could be beneficial for worry about cardiovascular disease, exercise. So not only does exercise help out the cardiovascular system, but there's new evidence that it might actually help rewire some of the effects after spinal cord injury in terms of the ability to control blood pressure. So there's definitely some benefit there. And the third thing is education. So there are printout cards that are available from Model Systems. We have some in the back from Christopher and Dana Reeve Foundation. They're great to have with you because when you go to the emergency room, now all of a sudden you don't need to explain all of that complex physiology. You can say, my blood pressure is usually 95, it's 165. Please read this, give me nitro paste. I need to be somewhere else. Additionally, if you'd like a refresher of some of the things that we talked about today, the New England Regional Spinal Cord Injury Model Systems has a video where I talk for about 8 minutes to get to avoid all of the immunohistochemistry that you learned. The link is there. So, in terms of take-home messages, AD is very common, ranges in spectrum of severity. Everyone is different in terms of how they present and the risk that they have for dysreflexia. We talked about all of that complex physiology. We know that people with spinal cord injury are at significant risk for cardiovascular disease, so decreasing AD in any way that's possible is definitely the way to go. In terms of medication insights, we talked about the nitroglycerin paste and the hydralazine being 97% effective. It's a great inpatient regimen. As an outpatient, using nitro paste is a great option if it's available. Additionally, lidocaine significantly reduces AD incidence and magnitude with those routine catheter changes. I should asterisk that and say that we have not tested that for people that do intermittent catheterization. So we're not sure and not advocating that people use lidocaine every time for that yet. To address dysreflexia, important to stay on top of bowel and bladder regimen, inspect your skin, exercise, and be prepared. So hopefully you all feel armed to identify autonomic dysreflexia and manage it if it occurs. And I welcome any questions either now or through other alternative channels. And I think we have a mic coming around if there are any questions. I think the first one's over here.
Okay, so first. Thank you very much, Dr. Solinsky. A quick reminder, as you pointed out, the handouts from the Model Systems Knowledge Translation Center are on the back table. We also have these little wallet cards that you can carry with you in case you ever do, you're seeking medical advice, have to go to the emergency room or anything like that. We have a fair number of these. If we do run out, on the back of this is also basically the same information that you can cut out and kind of make your own wallet card. So a couple of good resources there. And with that, we'll take any questions, and just a quick reminder to please raise your hand and we'll come to you with the microphone.
I don't need the mic.
Well, it's just with that, we have people online that need to hear you too, yes.
Bolivia needs to hear you.
The majority of the time when you're in the emergency room, when you ask for the nitro paste, they obligated to give it to you, or do they pretty much offer it every time? Would they?
They're not obligated to. I should qualify this that I tend to hear just the horror stories. So definitely getting medications in that scenario where your blood pressure is not coming down is appropriate. The horror stories that I hear are people saying, oh, you're just too anxious. Let's make sure everyone is out of the room. Let's turn off the lights, things like that. Stressing that is probably not the best option when your blood pressure continues to rise and that medication is the best option. And then handing them the wallet card is the route that I would go.
Repeat the question for the web test.
Sure.
Have you ever sorry about that. Have you ever noticed any connection with AD and spasticity, whether it's a protagonist or antagonist?
Yeah. So the question was about relationship between AD and spasticity. Very connected, quite literally. The way I like to think about it, and a lot of the kind of weird things that happen together, is the abstract concept that there's just increased activity happening inside your cord. So if all of your sympathetic rewiring is firing at the same time, there's other things that are going to get hit. We see that with people having spasms when they have AD, and some people don't have spasms, depending on, again, what the rewiring is. But we see that other places too. We see people say, my neuropathic pain is worse on non-bowel routine days, or right before my bowel routine, because that's the longest possible. So that is, your bowel is distended, there's increased signal happening inside your cord that amplifies the pathway that's leading to the neuropathic pain. So that conceptually, that's how I rationalize that. That's a great question. Thank you.
Hello? Oh, Jesus. Does how does AD and fibromyalgia, does the fibromyalgia make AD worse?
That's something I'm not sure about. So the question is about relationship between or amplifying effect of fibromyalgia on AD. We are learning a lot about fibromyalgia just within the last 6 months. It's definitely hard to make all the connections. A lot of times, the studies that I'm familiar with, at least in terms of fibromyalgia, are more changes in your brain in terms of how you're processing signals. So in that setting, AD wouldn't necessarily interact since it's happening mainly below level of injury. But again, that is knowledge from the past 6 months, and I would wager that in 6 years or 16 years, our understanding is going to be very different. It's a great question. Thanks. Yes.
So you mentioned the connection between spasticity and AD. So I was wondering if there was any research on the muscle relaxers that you might take for spasticity and its effects on AD.
Yeah, that's a really good question. The question was about relationship between muscle relaxers and AD. Muscle relaxers can kind of fall into a broad spectrum of things. You can give Flexeril and things like that, which act more centrally. But for this purposes, I'm going to say baclofen because I think that's something that people are most familiar with. So oral baclofen, I have not seen anything that relates that to dysreflexia. There was a really interesting study that came out of Cleveland 2 years ago now, where they looked at autonomic dysreflexia before and after people got intrathecal baclofen pumps. So baclofen getting pumped directly into the spine. They showed that the incidence of dysreflexia that was reported, so it's far from scientific, dropped from about 75% to about 5%. Scientifically, that kind of makes sense. Baclofen decreases the signal firing, and why should it not hit autonomic fibers in a similar way to it hitting motor fibers? So I think that there's probably some relationship. In terms of oral medications and taking baclofen, I haven't seen anything relating those two.
We have a question from the webcast, if we could.
Hi, hopefully everyone can hear this. We have a question. It says, after intense fatigue, I tend to sweat a lot. Would this symptom of sweating be indicative of autonomic dysreflexia?
That is a very tricky question. The science of sweating is relatively fleshed out. The science of sweating after a spinal cord injury is no man's land. So I've talked to many people about this, many experts, and they all give me different responses. I would say that sweating after exercise is a normal response. Sweating with transferring in a Hoyer is not a normal response. So having your knees brought up to your chest, putting all that abdominal pressure and getting sweating, that's not something you would normally sweat from. That second one would be the one that I'd be worried about. Potentially there's dysreflexia there.
Okay. I have one more. A systolic blood pressure of 160 in a non-SCI population is usually not life-threatening or likely to lead to a stroke, correct? Is this number a risk for people with SCI, or is it the risk of the number continuing to rise if the dysreflexia is not addressed? That's the real risk.
So the question was systolic pressure of 160 usually isn't a risk factor for some of the things like stroke or retinal hemorrhage. In a non-SCI population, is it a risk factor for those things in SCI individuals? I would say that we don't know. We don't have a great idea of what that pressure threshold should be. There has been some recent reports that threshold might be lower than individuals without injury. And I'll reference one specifically. So with increases in pressure in individuals without injury, without spinal cord injury, you can get this symptom or this condition called PRESS, which is posterior reversible encephalopathy syndrome. Basically, the vessels inside your brain get leaky and put all this additional pressure inside your brain. It leaks out fluid, puts in pressure. Likely because of altered cerebral autoregulation in individuals with spinal cord injury. There's some evidence that exists for individuals with high-level tetraplegia. there's been cases of individuals with SCI having press with pressures of 160, 170, 180. So it's just that change in pressure because of the altered blood flow and the way that it changes inside the head, that they were able to have those symptoms. So I that's not a great answer, but I think that the threshold is probably lower than individuals without SCI.
I just have a part of it is a follow-up to the earlier question about spasticity. So my father was given gabapentin. I think it was for spasticity. Have you heard anything like that? Gabapentin for treating spasticity?
Sometimes. Not one of the go-tos that we use, but there are folks that say that their spasticity feels better with gabapentin.
Okay, and the other is kind of a clarification about the using lidocaine for treating bladder. Were you saying to use that on a regular basis, or whenever you're changing catheter, or only when someone is having an AD episode to then do that?
Right, so the question was use of lidocaine routinely or just with AD. For people that have chronic indwelling suprapubics or Foley's, using it routinely can actually be beneficial. Usually those folks have their catheter changed every 2 weeks or commonly every 30 days. So it's not too much of an additional cost to use a little bit of generic lidocaine and decrease any AD that might happen with that. In the grand spectrum of things, if someone's having 10 to 15 episodes of AD every day, and we decrease that to 9 to 14 one day every 30, I'm not sure how much that will affect the ultimate outcome, but I think it's something.
Great presentation, thanks a lot. Yeah, exactly. You mentioned cerebral autoregulation a couple minutes ago, so just a general CNS question. Are the mechanisms that give rise to AD the same that give rise to cerebral autoregulation, or is it like a parallel process? Or does someone who is experiencing AD also is having autoregulation dysfunction in the cerebrum?
Okay, I'll repeat that one. So the question was a scientific question about cerebral autoregulation, which is how well the blood vessels in your brain buffer changes in pressure, if they can get bigger when they need to, if they can get smaller when they need to. If that's related to the same mechanism that causes autonomic dysreflexia. The answer is we don't know. So the cerebral autoregulation literature is kind of all over the board. Some people think it's altered in spinal cord injury. Some people think that it's not. My gestalt about it is that just like everything, there's probably a spectrum of it. There's some people that have altered cerebral autoregulation, some people that don't. Just the same as there's some people that have problems with their skin, whether they're going on an airplane ride and they develop a pressure injury, and some people that can ride around in the back of a hay wagon for 2 weeks and never have any skin breakdown. Part of that, or at least the way that I start to rationalize that, is there's probably something that's different in the autonomic nervous system and what's intact in each one of those individuals. And hopefully with some of the kind of autonomic phenotyping that we're doing, we can start to make some of those connections and say, this is someone that we need to be really careful about their skin, or they're going to be at high risk for press, or their autonomic dysreflexia is going to spike up right away within 2 minutes, and this person's probably got 15 minutes and it's going to kind of slowly build. In my dream, that's what we figure out. Thanks.
This is sort of a statement, but I'm a quadriplegic, and I was going into a building several years ago, and I hit my foot on the door going in. I went to a meeting, and I was there for about an hour and a half, and I started to feel the symptoms of AD. And I didn't know what was going on. So I quickly went home, and my caregiver at home looked at my skin. We checked my catheter. We checked. I knew my bowel care was fine and everything, and but my AD symptoms continued to go up and up and up and up. And then finally, he lifted up my leg, and I had fractured my tib fib, my leg. And as a quadriplegic, I didn't feel it, so I didn't know it was broken. And it was broken that whole through that meeting and on the way home and everything. So just another caution for quadriplegics or paraplegics that don't have sensation, that if there's AD going on, there's something the matter.
Yeah, that's a great point. And in the scenario where you wouldn't have found out what it was, you did all the checks that you were supposed to, nothing came up, that's when it's a good time to say, all right, I should probably get some help. I should go seek medical professions, opinions. There's definitely weird things that can happen. People have pancreatitis, people have gallstones, issues that you wouldn't necessarily be able to find. Women go into labor. All of these things happen and can lead to dysreflexia. And sometimes, it takes another set of eyes to really figure it out. But that's a great story. Thank you. Sure.
Okay.
Yeah.
Okay, we have a couple more from our attendees via webcast. So Aaliyah says, in my program, we are taught to have the patient chew oral nifedipine rather than hydralazine, as hydralazine has a longer effect on blood pressure and therefore can cause bottoming out of blood pressure once the noxious stimulus is removed. What is your opinion on this?
Yeah, so currently in Europe, they use nifedipine as their first line agent. Prior to 2001, nifedipine was the medication that was used almost ubiquitously across the US. Typically people would bite a tablet of nifedipine and kind of spray it underneath their tongue in the liquid form, or they would chew on it. It definitely has longer effects. How it compares to hydralazine, I'm not sure. I still think that first line nitro paste is warranted across the board. The reason why nifedipine isn't used in the US as much as it was in the past is that there was a warning that came out in 2002, that was a black box warning that talked about there's been several people that have passed away because they were given nifedipine, their blood pressure bottomed out, and they weren't able to be resuscitated. So because of that, many sites stopped giving nifedipine and switched to other agents. And that's the primary thing that I would note. When we used hydralazine in our protocol, we did have 4 people who had adverse events out of the 455. All of them were pressure going too low. One person got midodrine, one person got a liter of saline, 2 people got transported to the ICU for observation and were fine coming back the next day. So there wasn't any long-lasting side effects, but something to keep an eye out for, definitely. When you're going with oral medication, it's going to stick around, whether it's nifedipine or hydralazine. That's something that you need to be aware of.
Okay, I have 3 that I'm gonna make into 2 because the 2 of them are related. But IB and Mario ask, what can help mitigate AD symptoms when doing digital stim and bowel program? And AD usually happens when the bladder is full. And then so if there's any way that the sphincter can be opened in a way that's less likely to provoke AD.
Yeah, so in terms of bowel care that prevents AD or decreases the likelihood, using lidocaine is a great thing to do with digital stimulation. If you do other agents like Enemies, there's an Enemies Plus that has lidocaine in it that you use, and that again is decreasing C fiber firing, which is decreasing blood pressure, which you are all well versed in now. In terms of bladder management, For people that have a lot of dysreflexia that's coming from their bladder, lots of times they have a little bit of leakage as well. Their bladder is spasming all the time. For those people, bladder Botox is the first and second stop that I recommend. It's been shown to decrease the incidence of autonomic dysreflexia, been shown to decrease incidence of urinary tract infections because you're not squeezing and generating all that high pressure inside your bladder all the time. So those are the two ways that I would address that.
I think as well, right, in the video, the 8-minute video, you talk about another technique for visual.
Yes, yes. So when you're having dysreflexia, kind of going off the spasms and the increased cord signal ideas, sometimes it can be hard to pass an intermittent cath. Just the same as there's increased activity in your cord, you can get spasms of that external urethral sphincter. So when you're trying to cath, you're just going against a closed door over and over and over again. One way to decrease that is lidocaine can help lubricate things and hopefully relax it. But the other thing, and that's mentioned in the video, is a technique called scissoring. So the external urethral sphincter that gives access to the bladder is wired in parallel to the external or the anal sphincter. Okay, those are right next to each other. So if you're having trouble getting a cath in through the urinary sphincter, what you can do is put 2 fingers into your rectum, just the same as you would do a digital stimulation, and make a scissor sign. That's dilating out the external anal, dilating out the anal sphincter, and that can, because it's wired in parallel, lead to some relaxation of the urinary sphincter at the same time, make the cath a little bit easier to pass. Sometimes also, if you're having trouble getting that cath in, you can just put a little bit of gentle pressure and not try to ram it in, which is what you want to be doing because you really want to drain your bladder. Apply some gentle pressure, and sometimes that'll help loosen it up a little bit so you can get it in.
Any other questions from the audience, or we have one more from the webcast, but happy to take any questions in the room. Okay, back to the webcast.
This one's quick. Me asks, do you think pain medications can mask the headache that comes from dysreflexia?
Yes. Yes, I do. It can mask the pain that comes from AD. There's also some, in some individuals, I see many caveats. I think it could. There is evidence in the spinal cord that there are opioid receptors there, and those cause some downregulation. The question that I've had a few times is, what if I just take a bunch of Dilaudid or, hydromorphone or other medications that are going to deal with the pain? Is that going to lead to improvements in my dysreflexia? The short answer is probably not. The longer, more complicated answer is, if you get a high enough dose, it'll probably activate those mu receptors inside your spinal cord, decrease some signal, but there's better ways to do it. For patients, as I mentioned, that are going under, or that are having giving childbirth, or have a child, I should know this term, that are having children, that process is not something that you could just shut off the painful signal. And so in those cases, there's different types of anesthesia that are given, trying to protect the baby, but decreasing signals inside the cord at the same time, similar to how an opioid would work.
Okay, we'll take one last question. Rosanna, if we could, in the middle of the room.
I'll just add on the last discussion. My baseline is 105, and I've nailed some 235 for the last couple ammo rides, and I'm actually full of fentanyl.
Really?
Is that normal practice, or should I not have them?
Yeah,
I'm sorry, fentanyl.
Yeah, no, yeah. So the question was about getting fentanyl.
What it does, it did.
Yeah, So fentanyl has a range of different effects. It wouldn't be the one that I would go to first. I would give them the card and say, we have an easier way that isn't going to stop me breathing.
Indeed. All right. Good. Okay, well, I think we need to wrap it up so that people can be sure to get ready and catch their rides at 8 o'clock. Please don't forget to fill out the survey if you haven't already. Again, we really appreciate your feedback. Remember that there's further handouts regarding autonomic dysreflexia on the back counter. Remember that Dr. Solinsky's video is available on the Spaulding New England Regional Spinal Cord Injury Model System website if you'd like to check that out or use it as a further resource. Our next Knowledge in Motion lecture will be May 16th, so please save the date. We'd love to see you all again, and I presume that the weather will be more favorable. Thankfully, we're all ready for that. And we can't thank you enough for joining us this evening. We really appreciate it. For both those here in the room and those that are on the webcast, we really appreciate your support. And last but not least, all of our staff will be around for a little while to help if you need assistance packing up. And I think Dr. Solinsky will also be available for a little while longer for any one-on-one questions if anyone would like to connect. So thank you again.
Thank you.